Megan Mamarella, Director of State Affairs for the National Association of Health Underwriters.
Name's Randy Gebhardt. I'm the president of Quantum Health.
My name is Michael Rubenstein. I write for Retail Clinician and Drugstore News, primarily about the convenient care clinic space.
My name is Janet Troutwine. I'm the Executive Vice President and CEO of the National Association of Health Underwriters in Arlington, Virginia.
You have to look at the underlying costs of what's driving up health insurance, and no universal access proposal can be put in place until you actually address those costs. 80% of claims are paid by 20% of the people. And again, going back to a lot of single-payer proponents do advocate that if you would go to a single-payer system, you would eliminate a lot of administrative costs. And administrative costs really only count for about 3% of the overall cost in that. And it's not, absolutely, we are huge components of health savings accounts and other consumer-directed healthcare proposals. One, because it encourages people to be more involved and more engaged. Again, health insurance is the only service in the country that you don't take cost into consideration. If your doctor says you need to have this procedure, you go ahead and do it. If you're buying a car, you are not necessarily going to say, okay, whatever they say will go. You will look up and do your research on it. And we think consumer-directed healthcare really encourages that, and the importance of transparency, of finding out how much a procedure is going to cost, and encouraging a consumer to put money into an account that is tax-free, that they can use. Maybe today, if you are 22 years old, you won't use all the money that's in your health account. But say 10 years from now, you develop diabetes or you develop a condition. You have this pool of money there that you can use for your costs. And we think this is a very good. A lot of folks come out and ask the question, is healthcare a right? Everyone in this country should have access to have health insurance, absolutely. But does it come down to something? What else in this country do we force people to do? Do we, is it in the Constitution that we have to feed everyone?
The major cause of today's healthcare crisis involves a number of different things. First of all, consumers are not really aware of the healthcare they consume. If with any other service, if we were buying groceries, if we were buying even auto insurance, if we were buying a refrigerator, we would ask many more questions than we do today. So the consumer is very disconnected from the actual cost of health care, and health care is what drives the cost of insurance, and that's largely fueling the crisis today. A lot of people think that there is a huge amount of administrative cost in the insurance products that people buy today, and they use that as their reason for saying that the government could do it better and that the government could do it less expensively. The fact is that there's not as much administrative cost in there as many people think. And the fact is that the government has the same administrative cost, and in fact many times more, just to maintain the bureaucracy of the systems that we already have. So it's really a pretty big myth that there is all this giant amount of administrative costs in private insurance today. It's just not true. A lot of people advocate that for a single payer system. They say that if we had only one payer, that it would be more efficient, and that could be the government, and that in fact the government would be the best payer, and that the government would in fact be responsible for providing health care for all American citizens. I don't think that's such a good idea. I think that the government in fact would not do as good a job, and in fact if we look at other countries that are held up as models for us to go to, in fact I don't think Americans would stand for receiving their health care under those types of scenarios. We wouldn't stand for the rationing that's involved in those systems. We wouldn't stand for the waiting lists. We wouldn't be able to access the types of advanced technologies that we have today. We have so many CAT scan machines just in the city where I live. In fact, more than all of Canada has. All of Canada, the giant Canada, more just than in Washington, D.C. And I personally know of people that have died in other systems, particularly in the United Kingdom and in Canada, while waiting for the health care that they would receive in a matter of a week or two in the United States. The government would decide when we can get in to see our physician. The government would decide when we can see a specialist, how long we would have to wait to get an X-ray or a CAT scan or an MRI. The government would decide all of those things for us. And in countries that have those types of systems, and a number of countries in the world do have them, people wait a very long time to get the services that we can get in a matter of days. Of course, when we say that the government is paying for all that, what we mean is that you and I are paying for all of that, because in fact the government is funded through our taxes. And in Canada, the rate of taxation is considerably higher than it is in the United States. It's a human right that we have a right to good health. We don't necessarily have the right to have someone else pick up the tab for that.
Benefits of community care are that the prices are transparent, for one. The fact that you can go into, like I said, a Walmart or a Target and actually see that the prices are, say, $29, $39, $45, $59, and you know exactly what you're getting. So if you go to McDonald's and you ask for a quarter pounder with cheese, you know that that's going to cost a set amount of dollars. Same thing with pharyngitis. You can go, or sore throat, more commonly known. You can go into a clinic and actually see that, hey, I'm going to have to pay $25 because I've got a sore throat. That's a nice thing. You're not going to be able to go into a primary care, your primary care physician, and actually say, hey, I need to get my sore throat looked after. How much is that going to cost? So that's sort of unique. The prices are almost always lower in a community care setting than it would be in your traditional primary care physician group. Yeah, I've known people, and myself, I've paid as much as $200, $250 to get a full workup, or to get a physical, or even to get a sore throat. It can cost as much as $160 at some point. Whereas you can go into a clinic and get $45. You can accomplish the same thing, and you're going to be able to get tests inside of a community care clinic, lab tests. You're going to be able to get a blood test. You're going to be able to get all the same types of tests, and in some cases, in a community care clinic, some of those tests are going to be instantaneous. A single-payer system would absolutely destroy the whole community care movement, and the community care movement is extremely constructive at this point and provides so much back into the healthcare system that it's, of all the consumer-directed healthcare movements and orders, convenient care is absolutely one of the most significant. And for folks to spend time in an emergency room for 5 or 6 hours is absolutely ridiculous, when they can go to a convenient care clinic, get taken care of in an acute care situation in maybe 10, 15 minutes. So from a wait time perspective, it's great. From a cost perspective, it's fantastic. So to be able to pay $45, $59 out of pocket and not get zonked with a $3,000 bill or $300 bill, whichever, which is enormous for those folks, is ridiculous. So I believe consumer-directed healthcare, and convenient care specifically, is one of the answers.
Well, I think, first of all, most Americans probably don't understand that the Medicare and the Centers for Medicare, I think, Medicaid studies, which set the pricing for reimbursement, they directly pay for about 40% of all healthcare dollars in America. Another 10 or 15% is Medicaid and other government programs that are tied to Medicare pricing structures. And then, very importantly, almost all the private insurance companies in America who commercially cover people with health insurance tie their reimbursement systems to Medicare. So this CMS agency decides, they're called CPT codes, procedural codes, and there's various agencies that decide what codes can be reimbursable by physicians, and then CMS decides how much Medicare will pay for each of those procedures, and then basically the market follows it. So there's very few markets where one agency with some people sitting in a room can dictate 40% of the payments in that market, let alone a market that's the largest sector of the American economy. And they not only directly control 40%, but they indirectly control probably 80 to 90% of all reimbursements to physicians and hospitals in the country. The main reason that Medicare is sort of the tail that wags the dog is because, number one, the numbers are so large in the Medicare programs, but also there's a big bureaucracy in Washington to control the Medicare program. Medicaid is largely run by the states using partially federal money, so it's dispersed against 50 states who figure things out in their own way. At least that's the theory. Medicare is all centrally controlled by a bureaucracy in Washington. That's one of the key things that many people in America are trying to get, is better primary care for the Medicaid population and the people who don't have insurance and the underprivileged. Because if we could get them primary care and preventive care proactively, they won't get as sick, they won't have to go to the emergency room and use the emergency room as their doctor, and there would be much lower cost. You know, one of the things a lot of people look at in contrast to Medicare and how it's centrally administered and controlled and run by government agencies, a lot of people contrast that with the Federal Employee Health Benefits Plan that the vast majority of all federal employees, about 9 million people, are part of. And that is government funded, and yet they turn the actual operation over to as many as 200 different private healthcare providers, which provide choice, innovation, variety to all those 9 million members who choose and they vote with their feet. If somebody's not giving them good value for their money, they leave and go somewhere else. If somebody's not giving them good service, they leave and go somewhere else. There's nobody dictating what the payments are and those types of things as there are on Medicare. So there are ways to have a sort of centrally administered or a centrally funded process, but not centrally administered and controlled. With the exception of the Federal Employee Health Benefits Plan, the vast majority of all other government programs that we've ever seen start out in one direction and wind up becoming a self-reinforcing bureaucracy. The way that it's evolved is in the typical way that federal bureaucracies evolve, and it's actually caused a lot more problems in healthcare than it's helped. Setting the scene for the free market to do what the free market does very well. Number one, there is a lack of information for everybody in the marketplace to make decisions on who's providing the best care, the highest quality care, at the most efficient price and cost. That information doesn't exist today, and there's a variety of reasons people say are causing that. But what the government could collect the information, put it in a national database, get apples compared to apples, and put it out there for the market to use.
Don't you think?
Well, you know, the notion of going to a single-payer system, in my opinion, is just crazy. Anytime you collect, ultimately it's going to lead to higher taxes. The money's got to be collected somewhere. You're getting centralized bureaucracy for all the reasons that you can see with CMS, which does have good intentions and does good things, but it becomes a centralized bureaucracy. You bring more to the center, it becomes very difficult. There's no way to administer a $2 trillion industry from a central agency like that. You know, the key lesson that has been learned by the countries that have had socialized health care or single-payer systems and is not the fact that the single-payer system works very well, because they're all trying to get away from that or trying to expand their horizons from that today. Well, you know, one of the arguments out there today that I think is a complete fallacy is that if you had a single-payer system, you'd have lower administrative costs, and then that same money could somehow be taken and given as health care to people. That might make sense, except for the fact that that hasn't what has happened in virtually every other sector of the American economy. Every sector is a free market sector, and administrative costs go down over time. They don't go up over time. The reason that administrative costs have gone up in healthcare is not because it's not a single-payer system. It's because of these distorted dynamics of a centralist party deciding what they're going to reimburse to whom for what.
My name is John Lenz, and I'm with CoreSpeed.
MRI.
So basically, if you look at the parallel with travel and healthcare, travel was deregulated several years ago. That meant that travel providers could go direct to retailers and consumers. Well, with HSAs, you have that same environment whereby a doctor can engage directly with a patient. Now, what happens when that occurs is there's a middleman that's taken out of the equation. So there's money left over. What can happen in that environment, we saw it in travel, was that the providers got more for their services and the consumers paid less because there wasn't a middleman in the middle taking their cut.
Okay. Los Angeles.
So when a patient does a search based on their criteria and what's important to them, they receive a list of doctors that can provide that care. They will also see the prices that those doctors are charging. Now, there's also the possibility for there to be an auction a la eBay or a la Priceline in the travel space. So literally, you're going to see pricing drop because most providers are going to want to have that traffic because they get instant payment, no bad debt, and the patient gets what they need when they need it. Medical devices have pricing that range all over the board. You can talk to one provider and it's one price, and another provider, it's double that price. So this will actually even out that pricing, and we saw that in the travel space as well. Initially, you saw widely divergent pricing with respect to the providers of travel products and services. And as time went on, and more people began to understand the transparency of that pricing, then the providers had to come on par or they would go out of business.
My name is Patrick Marsick. I'm the Managing Director of MedRetreat. MedRetreat is a medical tourism service agency facilitating patients from North America seeking treatment abroad at affordable prices in a timely manner. For North Americans seeking affordable health care abroad, the savings are anywhere between 50 and 80%. Healthcare has really come a long way. They're utilizing the same equipment, the same technologies, and in fact, many of the surgeons are either US, UK, or Australian board certified. They cross-train with hospitals such as Mayo Clinic, Cleveland Clinic, Harvard International. So the quality of healthcare has really come a long way in the past decade, and the reason for that is these hospitals abroad realize the potential of medical tourism and offering these services to Americans as well as Canadians. There are organizations that do accredit hospitals overseas. One of those such organizations is the Joint Commission International. The Joint Commission International is actually a spinoff of JCAHO, who accredits hospitals in the United States. Among Joint Commission International, there are other organizations, international organizations, that do measure and pretty much accredit these hospitals for quality and safety. Typical hip replacement in the U.S. can cost anywhere between $40,000 and $65,000, depending on what hospital you go to and in what part of the country. So let's use $50,000 as a starting point. To receive the same procedure overseas, you're looking at roughly about $10,000. That's for the procedure, it's for the doctors, fees, anesthesiologists, medications, hospital stay. By the way, it's 3 times longer than that in the U.S. In the U.S., you'll typically spend about 2 to 3 days in the hospital after hip replacement. You'll spend 8 to 10 days in the hospital overseas. One of the reasons medical tourism can be part of the solution to America's healthcare crisis in that it reduces costs. Now, currently, the main market is the consumer market. It's for people who are uninsured or underinsured, or those seeking elective cosmetic and dental surgery, as well as patients from Canada who have to wait in long lines to receive their health care. In fact, this is a viable alternative for government as well. This could be a way that they can start controlling the healthcare costs. And perhaps as a result of offering overseas service, that will allow the American Healthcare Society to come up with some creative ways to make our system better.
My name is Tom Johnsrud, and I'm a senior consultant for Parkway Health, which is based in Singapore. Parkway Health operates about 22 facilities in Singapore, India, China, Brunei, and Malaysia. American patients should consider going abroad for care because it's an opportunity for employees of those companies to be able to take advantage of a lower cost but high quality healthcare system. International providers based on accreditation standards are equal to, if not sometimes better, than domestic hospitals here in the U.S. It's practical in many situations for an employee to go overseas for care, particularly when it's non-catastrophic, non-emergency type procedures. Having a hip replaced, a knee replaced, having a heart procedure done, that's not an emergent situation.